Our last talk, ventricular ablation using high-energy heavy ion beams, Amanda Deischer.
Thank you again for inviting me to join this session. I have no disclosures, but I do have very many people to thank, both from Mayo's Cardiovascular Medicine Division, as well as Mayo Radiation Oncology. In particular, I'm highlighting Dr. Packer, who you might notice was the original speaker for this topic in your program. Right. So as I talk about VT ablation with external beams, I have the advantage of being the last speaker of this session. So they've already talked about the advantages and the challenges of hitting these targets with radiation. What I'm going to offer you as the final speaker is a choice. You've heard a lot about X-ray radiation, but there's also other radiation forms out there, such as external particle beams of protons or carbon. And I'd like to make a case for considering those. But before I ask you to decide, let me tell you a little bit about the differences between X-rays and protons. So if you're trying to treat this target in blue, it's usually nestled between a couple of organs. If you bring in X-rays from the left side, you'll see the dose increases towards the surface, and then it falls off and attenuates. But if you bring in protons from the left side, at a certain energy, they penetrate, they slow down, and then all of their energy is deposited at the end. And if you add up a lot of proton energies, you can get this nice spread out, flat, homogeneous dose distribution in your target. And you'll notice a couple things about this plot. One, there's no exit dose behind the target for protons. And two, there's really not that much entry dose for protons either. So it's pretty easy to build these things. Like the Mayo machine has 93 energies to choose from, so we can treat up to 32 centimeters in depth. And if we move from 2D to 3D and want to deliver this to, say, a brain tumor, which is what we're more often treating than hearts, you can see that you dial up the energy, and the most recent technology to deliver this is pencil beam, which is, as advertised, a pencil of protons, where you paint spots across a tumor in a layer, change the energy, treat the next layer, change the energy, treat the next layer. The advantage of this approach, you'll notice, is there's no dose behind the tumor, and there's no dose that's outside of the entry path either. So this spares an awful lot of tissue and treats a very homogeneous region. Okay, so which one do we choose in radiation oncology? Well, the best answer I have is it depends. There are some slam dunk choices. One is with pediatric tumors, say treating the whole cranial spinal axis. On the top, you'll see an X-ray distribution, one posterior beam coming through in order to treat that whole region. And on the bottom, you'll see what happens with protons. And the big difference here is, of course, the exit dose. So these patients are going to live 60 more years, and this patient on the bottom will have fewer complications because they have no heart dose, no esophagus dose, no small bowel dose. So how about for cardiovascular targets? So on the left, I'm showing an image of an X-ray treatment treated with, which is planned with 3 arcs, so half arcs, going around trying to spare half of the lung. And you'll see that there's a bright red region, which is full dose to a target. Now on the right, we'll show a proton treatment with 3 beams. Again, the red region is full dose, very similar on both sides. But what's different between these two is that blue region. And I've set the color scale to go from 30 gray as the prescription dose at the top in the red to 500 centigrade at the bottom as a low dose region. Now, is the difference between these two clinically significant? I can't tell you right now. It depends on what is a safe dose in a single fraction for a heart. In radiation oncology, we avoid giving dose to the heart. So you've brought us into this new realm where we don't know exactly what the effect is for these patients long term. So as we go about answering this question, one of the ways that Mayo Clinic is doing it is with preclinical studies in an intact porcine model. And I want to show you some data today that has not yet been published, in particular from 20 healthy domestic swine, where we targeted 1 to 3 areas of the left ventricle, delivering 30 to 40 gray in a single fraction. But I also want to get you to pay a little bit of attention over the next year as we publish some other data coming from an infarcted domestic swine model. But this data is still maturing. We're trying to follow these animals out to approximately 1 year, and we're not there yet. So as we look at this data and we're trying to figure out what dose is safe, what dose causes what level of damage, some of the assessment tools that we're using is baseline MR and cardiac 4D CT. We're doing MR and MRE every 4 weeks. It's an awful lot of scans for an awful lot of pigs. And at in-study, we're doing EA mapping, explanted MR, pathology, and histology. So I'm going to do one quick radiation oncology slide because I'm a radiation oncology medical physicist. And this is just to show you that we work really, really hard to get the right dose to the right location so that the picture you see on the previous slide is exactly the dose that's delivered to that heart so you can look for the effect later on. So we're managing respiratory motion by imaging and treating at end expiration. These pigs have very regular breathing patterns, so it's pretty easy when they're on a respirator. And for cardiac motion, we're making sure we incorporate that motion into the planning CT and that we are repainting the protons during delivery as well. And I just have a quick picture of the Mayo treatment room to show you we're also using every imaging thing we can throw at it. We have 2D imaging, we have volumetric imaging from CT on rails, and we're really making sure that the fundamental thing that we need for every radiation oncology dose-finding study is that we deliver the planned dose to the planned location so that we can believe the results. And every study you've seen tonight works really hard at that as well. Okay, so what sort of results? These are the fun last 4 slides. All right, so what have we seen for lesion development? This is an example of a pig that had 12 weeks of follow-up. He had 3 targets treated to 40 gray. On the left, you see a planning CT showing the high-dose regions in red, and then we see MR every 4 weeks, and then the final growth pathology. So even a physicist can see the lesion in the growth pathology slide on the right. But to help a little bit, we've got these yellow arrows that show the lesion in the MR. So the lesion shows up as a dark area surrounded by a delayed enhancement contrast area, showing that there is some microvasculature damage that's been had. Now, if we take that image on the right and look a little bit microscopically from the macroscopic, I want to draw your attention to 3 regions in particular. In the upper right, you'll see this zoomed-in region of the endocardium, so you'll notice that it's smooth, even after being in the high-dose region. In the core region, you'll notice there's a whole lot of necrosis. And in the border region here, you'll see necrosis, hemorrhaging, fibrosis on one side, and relatively normal tissue on the other. So where is this dose line? Well, for the intact porcine model, what we're seeing right now, and we'll see if it continues to apply to human models, and as our studies go on and we get more data, it looks to be somewhere near the 20 to 30 gray line. So as we look at these lesions over time in all 20 of these animals, some of them have 1 to 3 sites, we can see what is the growth of the lesion. We do see there's definitely a ramp up, a growth, and then sort of a plateau. If you look at them sort of aggregately, you see the same ramp up and then plateau. And it looks like this ramp up plateau ends around 12 to 16 weeks. So the majority of the lesions will plateau by that time. So this is important if you're looking for effects. When do you look for the effects? So wait at least 12 to 16 weeks if you're looking for MR to see what the final level of damage might be. Another thing we notice is that we can actually subdivide this cohort into 2 subgroups. A high dose, where these animals received 3 targets, 40 gray each. And then there was sort of a lower dose on average group where they either had 1 target or maybe 2 targets treated to a lower dose. And I'm going to take a second to explain this graph on the bottom left. This is showing the dose on the x-axis and the percentage of myocardium that is getting that dose on the y. So say if we look at the 5 gray region, you can definitely see the low dose group has only maybe 30% of the myocardium getting 5 gray versus 70% in the high dose. And you still see that difference all the way over to 20 gray. You see it in the mean of the dose. And this becomes important because we happen to notice that there is a correlation between the amount of amount of your heart that's getting 20 gray in the intact porcine model and the change in the left ventricle ejection fraction as calculated from MR after 100 days. And this dose is looking to be, at this point, significant. Okay, so in summary, this radiation oncology plus cardiology partnership I've been part of has been really fun and really fruitful. And it's still going because I think there's a lot of work out there to do. But we've been able to combine our knowledge, technologies, and techniques with the end goal of improving options for patients with VT. So there's a lot of investigation that is ongoing. There's a lot of dose finding that needs to be done, both the dose for the cure. So why treat with 40 gray if you can do it with 30 or you can do it with 20? Makes life a lot easier as far as complications, but also the dose for complications. What sort of macroscopic, microscopic ejection fraction changes are we expecting at different dose levels so that we can find the best choices for our patients? And I'd hope I convinced you at this point that a pencil beam scanned particles, be it proton or carbon, which has similar properties, are an attractive choice for VT ablation. There's no exit dose. You can do it in just a couple of beams. This gives you smaller volumes receiving intermediate and low doses. and, depending on how the data pans out, possibly lower rates of complications for your patients. So, thank you.